Okay. This is an ankylostomiasis. Right. Tropical and subtropical regions. So far, some of these are basically in tropical and subtropical regions. All right. Second most common worldwide. Two big ones that we're going to talk about: the ankylostoma ordinale and Nectora americanus. Yes, Nectora americanus is generally the one that we find here in the U.S. more commonly. Right. So the infected eggs are laying around in soil. You walk around barefoot. This thing attaches to your skin. It penetrates your skin. It gets to your portal system. Gets to your portal system. Goes to your lungs. Gets into your alveoli. Breaks out of your alveoli. Comes up your bronchial tree. Goes to your trachea and epiglottis, and then you swallow it. That's how it makes it to your intestinal tract. And then in the intestinal tract, it just hangs out. Okay? It latches on and it feeds on your blood. That's what it does. There's going to be two types of hookworms. This is the one that we talk about, which will be intestinal. Here in a little bit, we'll talk about the other one that's cutaneous. All right? So keep in mind that we're going to have two of these. All right, here's your life cycle. Okay, here's the three different ones. So if you look at the three different ones, if you look at their attachment points, it's one of the ways that you tell the differences between each one of those. So you have your infected egg, it becomes a ruminiform outside, hangs out, you walk in the infected soil, it attaches to your bare skin, whether it be your feet, whether it be your hands, elbows, whatever's touching the infected soil, penetrates it, gets to your lungs, and then you swallow it, and then it just hangs out in your intestines. Okay, generally, or initially, asymptomatic. You can probably highlight that ground itch at site of penetration. Okay? So wherever it ended up coming into your system, you get what we call a ground itch. That ground itch ends up becoming a little bit irritated or a little bit inflamed, and it becomes itchy. So we call it the ground itch, and that's generally where it actually penetrated. It may actually become a little vesicle or a little rash right at that site. As you can see, because it's sucking your blood, it may cause you some iron deficiency anemia, which is one of the most common symptoms of this thing. And with that said, you guys remember what pica is from psych?
Chewing on the things that are nutritious.
Yeah, non-nutritious stuff, eating dirt, chalk, clay, starch, stuff like that. Right? So the thought process is because you're iron deficient, it's one of the things that they think is causing you to do those kind of things. And then you'll have chronic protein malnutrition because this thing is sucking so much blood from you, right? And it's causing you that iron deficiency anemia and malabsorption of nutrients. So test, what are you going to do? This thing hangs out in the intestinal tract, O and P, right? So for those eggs, and you have to do more than one. Right? You may have to do more than one O and P. I'm not going to be extremely concerned about morphological identification just because we're going to treat both of them the same way. Here's the deal. Overseas, they don't have all these medications, so sometimes when you have a light infection, usually you don't do anything. The body sometimes can take care of it and it makes it go away. For light infection, especially if you're asymptomatic. If you are not asymptomatic, if you're malnutrition, if you are immunocompromised in any way, shape, or form, then go ahead and treat. Okay? And then albendazole and mebendazole are the two methods that you can use to treat. These things are really small, so you can have a whole bunch of them in your system and not even realize it. Here's some little circles showing you what they look like. So look how small they are. Okay? They hang out in the rugae, so you can have hundreds and hundreds of these guys and still not have any abdominal distension or anything just because they're so small. All right? These things are 0.3, 0.4 inches. Really, really tiny. the duodenale, I think, is a little bit bigger than the Americanus. Yeah. Asperis. All right, so I found a video of Asperis. Asperis is the largest round worm that invades our body, but the system wouldn't let me play it for you guys. All right. Okay, this is the most common intestinal helminth infection in the world. All right. This happens worldwide, mostly in tropical countries. It does happen sometimes in the southeastern aspect of the United States. So yes, it does happen here. All right. Usually we're infected by Escherichia lumboides when we ingest the eggs. Okay. Often from contaminated food or contaminated human waste when we push it out. You're going to have contaminated vegetables, food, or water also. And spread this. Here's everywhere in the world that it's at. As you can see, it's almost everywhere, to include the southeast U.S. Fecal oral, ingest the eggs. Excuse me. Right, so it's got to go through its life cycle. This one's a little bit different. It's got to go through its life cycle. This life cycle means that once you eat it, it goes to the intestinal tract. Right? It likes the duodenum. Okay? They lay the larvae in there. The larvae penetrate your intestinal lining, your intestinal wall. It gets into the portal vessels, goes up to the lungs, gets caught up in the alveoli, breaks out of the alveoli, finds out the bronchial tree, the trachea, and your epiglottis, and then you swallow it. And then it goes back down into your intestinal tract again, and then it lives out its life, hatches some more eggs. They continue to penetrate and it continues to go in a nice big circle. All right. They usually release about 200,000 eggs per day, so it's quite a bit, right? Now, these guys do have like little hooks to kind of hold on, but they usually like to swim around in your intestinal tract. Unlike the other ones where they have hooks or suckers where they actually lynch into your mucosa, submucosa. These guys kind of just hang out there and hold on because they have the mouth, stomach, and the anus. So as the nutrients come through, they just eat it and pass it. Okay? No need to actually hook into you and suck your blood, right? Like the hookworm does. Now these guys have a lot of what we call worm burden. Okay? Remember what we talked about yesterday when we say worm burden, it just means there's a lot of worms in your stomach, in your gut, okay, in your intestinal lining. With these guys, they become so overburdened in your gut that sometimes they may come out of your mouth or nose, and sometimes they may come out of your rectum. Okay? Not to mention, these things are really big. Remember, these guys like to hang out in the duodenum, so it puts them really close to the stomach, which allows them to come back up, to come out of your nose and your mouth when they have an overburden. All right, so if you look at the life cycle here, right, you get contaminated with the eggs, you eat it, goes down, gets into your duodenum, they hatch the little larvae go and break through your intestinal tract, go up to your lungs, and then from your lungs it goes back down. Okay, nice little circle. Circle of life, there you go. Okay. Initially, just like all the other ones, there's no acute symptoms. Right? But these guys deal with a very high worm burden. Okay, not just because they have 200,000 eggs per day, but they're a lot larger as well. They end up getting entangled. They entangle themselves so that they can kind of stay in the same position within your intestinal tract. So at that point, you may end up having some abdominal pain. If you have so many, it can cause intestinal obstruction, at which point, instead of diarrhea, you may end up with constipation. Right? Now there it tells you migrating adult worms may go other places. And there it's got the oral expulsion, which means it may come up your stomach, up your esophagus, and out your mouth or nose. Right? That's just because there are so many of them. And remember, there's other places they can go and other things they can block. They can block your pancreas, they can block your gallbladder, they can block your appendix, at which point they can cause any of those issues as well. So other things to keep in mind with aspirates. Now, because this one does have a lung phase, right, the little larvae break through the intestinal wall to the portal system all the way up to your lung. In that lung phase, you may have cough, dyspnea, hemoptysis. Remember that Lomper's syndrome where your macrophages are going and causing a hyperinflammatory reaction. So, in small chances, you may also get those eggs or those larvae in your sputum. Okay? So these guys hang out in the intestinal tract, so stool low and pee, just like all the other ones. But in very rare cases, if you do catch it during the lung phase, you may catch something in the sputum as well. Okay. Microscopic identification of the eggs is the biggest thing to do. Okay. Here they've got barium examination of the intestines. Barium may not make it all the way through, depending upon the worm burden. Okay, because if you've got a lot, this is not going to make it all the way through. Treatment, albendazole or mebendazole. Okay, real easy. Simplest thing to do is just do stool samples for a couple of days. If you don't get it after the first go around, and look at it under the microscope. That is the easiest thing to do. These worms will probably be radiolucent, so if you do an abdominal X-ray with this barium examination, you may see them. Okay, see all these little white things in here? Okay, this brown stuff is poop. Okay, this is the opening of an intestine. These white things are all the worms that are in this guy's intestinal tract. Alright? That's what all these little white things are. So here, you can actually see the outline of one of the worms. Okay? And it's circled in here for you to actually see. So real good one right here, you can see them all curled up. Enterobiasis, aka pinworms. More frequent in children, even though adults can still get this thing. It's more frequent in children because they can pass it to each other, and they hug each other, scratch each other. Their hand hygiene is not as good, and hand hygiene is extremely important with enterobiasis formicularis, because if you do get it under your fingernails when you scratch your rectum, this thing does cause perianal itching. You can spread it to other things. So if you have fomites, like toys, sheets, you may spread it to those things. All right? Transmission basically is fecal oral. So you can see the size of them, right? 8 to 13 millimeters, adults 2 to 5. They're very, very small. But if you do get them on your clothes, and you get them on your sheets, and you shake them, you may aerosolize them. In which case, if somebody's around, they may inhale them. That may be another way to get it. Right? But more frequently is in children versus adults. Okay. So here you can see the most common helminthic infection in the U.S. Usually you see a lot of that in daycares, in child care centers. So, just the egg, immature and reside in the colon. This one is different than all the other ones. This one is home, where it likes to hang out, is the colon. Okay, so this one's different than all the others. Okay, and there it tells you female pinworms travel to the anus at night to lay their eggs. Around 11,000 eggs per night, which is one of the reasons why you have the pruritus ana. They kind of mature in that colon area, and you go out at night to your rectal area. They lay the eggs. They lay the eggs in this gelatinous substance, right, for protection, which is one of the things that also irritates your rectum, which causes you to itch, to include the movement of the worm in your rectal area, which also causes you that crisis. So you have multiple reasons why you get that perianal itch. Now, remember, if you do scratch and you don't wash your hands, you can put it on other things. And one of the reasons why kids get this more common than adults is because if they don't do their hand washing appropriately, they can get it on their toys, okay, or other furniture. Okay. So even if you do take care of it initially, if some of these other things are not clean or washed appropriately, you can get reinfected with this stuff. On average, this stuff can live on these fomites for about 3 weeks or so at normal room temperature. So even if you haven't treated for it, taken care of it, if you haven't cleaned everything else, the stuff can still hang out for about 3 weeks. And here you got hands and fingernails is probably the biggest deal for spreading this stuff. So hand hygiene extremely important. Okay. And there they got pajamas, bedding, and if you do fluff things out, you may aerosolize it. But that one is a little rare, not rare, people will look at it. Okay. Generally, you could say symptomatic. Okay, the most common thing for this thing is the perianal pruritus, specifically at night. That is the most common in a child. And so if you see, a parent bring a kid in for perianal itching specifically at night, one of the first differential diagnosis should be enteromyces, okay, pinworms. Now, I would say highlight rectovaginal fistula, because that is an extremely important thing to look for when we talk about females. Right? So rectovaginal fistulas can be caused by a bunch of different things. It can be caused by trauma. It can be caused by childbirth. And the reason why it's important is because that rectovaginal fistula is a little passageway from the rectum into the vaginal canal. So that means that these little pinworms can go from the rectum into the vaginal canal. Now, it's going to cause vaginal itching, and it's going to cause several other things that we do once it gets into the vaginal canal. So it's important to ensure that if you are looking at older females, that they do not have rectovaginal fistulas. If they do end up going into the vaginal area, the body is going to try to get rid of it, at which point it may end up forming neogranulomas, okay, in those areas. So you may see some granulomas in those areas. And that's the body just trying to take care of it. And there's some of the other symptoms, anorexia, irritability, abdominal pain. And then again, just like some of the other ones, if they do end up migrating backwards, because they do end up becoming an overburden, they may block up your little passageway to your appendix, causing some possible appendicitis. Right? If it does get into the vaginal canal, it can make its way up to the uterus and block up your ovaries, your ovaries, causing you cellulitis. So it's kind of important if you have a female with rectovaginal fistula to ensure that it's taken care of. And rectovaginal fistula should be addressed via OBGYN, because depending on the size, it really should be surgically repaired. How do we find these things? It's like all the other ones, right? It lives in the intestinal system, it's an OMP. Now, you guys remember we talked about putting a little tape next to the rectum. This is the same thing. We'll put a little tape or cellulose tape next to the rectum for little kids, particularly at night. And we'll see if we can get little eggs so we can identify. Very rarely will you get a little worm stuck on there so that you can realize and identify the worm type. But that's very rare. Okay, so what are you going to use? Albendazole. Make sure you educate the family. That's extremely important because they can spread it, right, through fomites. Make sure that they wash all their bedding and clothing. Wipe down all the toys and furniture, including toilet seats. Okay, prevention is key for this because if you don't do good hand hygiene and wash everything else, you can still spread it to yourself again, even if you've been treated before. Cutaneous larva migrans. Okay, this is the skin manifestation of the hookworm. Okay, talked about the other hookworm. The other hookworm went up and then back down into the intestinal tract, hooked in to the duodenum and jejunum, and starts sucking our blood out. This guy doesn't do that. Okay. This thing occurs worldwide, Anklostoma caninum. Okay, just like the other one, this one penetrates your skin. Right? We're generally accidental hosts. We're not the people that are actually supposed to get infected. Okay? Generally in tropical areas, associated with walking barefoot on beaches. It's not just beaches. Any infected soil, commonly beaches, any infected soil will cause this. A lot of times we'll see this in little kids because they have those sandboxes or the ones that are playing out in the dirt. They end up getting some of these. Intense pruritus at the area that it penetrates. And it generally stays in the area that it penetrates. It just goes subcu. Okay? So it just goes subcutaneous and it just stays there, right under the skin. Okay? Here it tells you it causes that linear lesions. If you guys remember serpiginous, that is actually what it kind of sort of looks like when it goes under the skin. Nice little raised, brownish discoloration of the skin. When you see it, it'll be very clear. So animals are usually definitive hosts. We kind of walk on the infected soil that the phytoforms are maturing in, penetrates our skin, and it just kind of hangs out wherever it penetrates. Okay? If it's your foot, it's going to hang out in your foot area. If it's your arm, it'll hang out in your arm area. Whatever area it came into contact is the area that this thing's going to stay. Okay? So this is kind of what it looks like. It's very telling. This is a clinical diagnosis. So if you look at this, is your serpiginous little S-shaped tract that this thing makes right under your skin. Right? You can just see it. Right? So this is very telling. Right? It's a narrow, burrowing larva. It's under your skin. Here's another one. Okay. This one's a pretty decent looking one right there. But generally this is just a straight out clinical diagnosis because you ask the questions, hey, what were you doing? Were you walking around barefoot? Yes. Where? Were you in an endemic area? Do you have animals that roam around there? Yes. Okay. It's a little kid that's playing in a sandbox, or a kid that's playing in dirt. Okay. Likelihood is very high. That's when you start building the different diagnoses, and this would be one of them. All right. So what are you going to treat with? Albendazole. We used to use ivermectin. I left it on there, but the FDA has made it a black box warning. Okay. So generally, not necessarily use unless we need to. Albendazole works just as well. Okay. So big things is just, right, prevention is key. So looking there for the endemic areas. Toxocariasis. It's either toxocati or toxocaninus. Okay, caninus is more common than cati. It says worldwide distribution. Okay, we're going to talk about two different ones here. We're going to talk about the visceral larval migrans and the ocular larval migrans. Very telling, right? Visceral means it's going to go to some organ, ocular, or your eye, right? Okay, life cycle, fecal oral. Okay, we are accidental hosts. We accidentally ingest eggs from contaminated soil that may be infected by some animals, in which case maybe dogs, maybe cats, and the cat eye and canine. Right? Now, other means that we can get infected by would be animals that we would eat that may be infected with it. For example, if you eat rabbit or duck and they are infected with toxocariasis, when you eat those and they're undercooked, then you end up getting toxocariasis, all right? So, not just one way, but there's several ways that we can get it. The visceral larval migrans, once it gets down into your intestinal tract, it'll burrow its way through your intestinal lining and it'll migrate over to the liver. Okay? It's one of the more common areas. It can go to your central nervous system, it can go to your eye, which would be the other one, it can go to your bones, it can go to your muscles, but one of the more common places that it likes to go would be your liver. And in a route, it usually damages a lot of the tissue that it comes into contact before it makes it to wherever it's going. Some of that is due to the actual species itself, and then other parts is the body's reaction or hyperinflammatory reaction to it moving and migrating to get to wherever it's going. So, multiple reasons why it causes a lot of tissue damage. So these two up here can in utero pass it to these little guys. Right? And these little guys, because we're always playing with them, a lot of times end up giving them to us. So once this thing goes out into nature and we ingest it, or your accidental guys, usually these guys are infected, then we eat those and then we get infected. So this one's a little bit different. Right? This one can be asymptomatic to mild febrile illness. Right? And that's specifically for the visceral larval migrans. Because remember, that one goes down, they both do, but this one's more specific because it's going to go to some specific organ that it chooses to go to, liver being one of the more common ones. And as it's going through and moving around, it's causing a lot of destruction to your tissues. So you're going to get quite a bit of signs and symptoms. And then really based on whatever organ it chooses is the type of symptomology that you're going to end up getting. Okay? Now if you look at the ocular larval migrans, that leukoporia, I don't know, do you guys remember what that is from ophthalmology? No, AT&T, no. That's the abnormal white reflection in the eye. Okay. If you do see an abnormal white reflection in the eye, it could be due to quite a few different things. But if you do see that, make sure you send them to ophthalmology, not optometry. Ophthalmology, you need to look into the back of the eye. A lot of times that is related to a retinoblastoma. Sometimes people have gotten those things confused and they have completely removed the eye because they thought it was a retinoblastoma, in which case it was only toxocoriasis. So that the ophthalmologists make those decisions. Okay. All right, so this is what toxocoriasis looks like. It's destroying this little area back here, the macula and your fovea, right? You're sharply getting the concentration of cones back there. It's destroying it, so your vision is actually being destroyed by the toxo. That's what leukocoria looks like. That's a white reflex in the back of the eye. So remember, these guys don't hang out in your intestinal tract, right? Once they get to the intestinal tract, they burrow through your intestinal wall and go to some organ, or if it's the ocular one, it goes to the eye. So you are not going to find any eggs in the stool for these guys. It's no OMP for you. And for these guys, during the migratory phase, right? Remember, whenever it's migrating, your eosinophil count will go up. So you can do eosinophilia with these guys. Other things that you can do ultrasound of CT or MRI, figure out where they are and how invasive they've become within the organ that they've chosen to attack. Okay. Once they've gotten to whatever organ, you can also use EIA or Lyme. Okay, and you can use that once they've gotten to wherever they're going to be, because you'll end up producing IgG, IgM, and IgE as well. Trichinosis, that is actually the new name for it. The old name was trichinosis. No big deal, the change was. But there's quite a few different species of these. They got Pseudospiralis, Tibia, Nelson, and Broli. But we are accidental hosts for this. Okay? Generally, this happens in predator species. Okay? Predator species animals, not necessarily humans. All right? The problem with this is that we accidentally eat some of that carnivore meat. So I would highlight carnivore meat. I would also highlight undercooked carnivore meat, improperly processed or stored carnivore meat. Okay. I would also highlight Alaska, California, bear, boar, or pork. Those are predatory animals that we generally would eat that may spread this to us. Okay. The thing with the speciation at the bottom there, it's kind of nice because if you figure out the species, you can kind of figure out the animal that it's affecting. So if you look at Pseudospiralis, generally it's mammals and birds worldwide. If we look at the TV, it's usually Arctic bears. So folks up in the part of the world usually eat bear, so they can infect themselves with trichinosis. This isn't a really big one. This one is kind of smaller, and usually there's about 10,000 worldwide, so it's not a real big deal. Here within the U.S., there it tells you it's usually about 25 cases per year, so it's not very big. I used to run the soldier medic training site out here for the whiskey program, and one of the medics went boar hunting and he brought in some boar meat that he dressed, processed. We barbecued out back. Nobody got sick, so I didn't want to. All right. Two different ways that we can get it. All right. So if you look at down here at the bottom, these are all your predatory guys, right? That's this sylvanic cycle just means that this is the cycle that happens within themselves. One has it, one eats it, and then they get it, and then somebody else eats that one, and they just continue to spread it for themselves. all this thing does is, once it gets into your intestinal tract, it bores through your intestinal system and it goes to any striated muscle in your body. That's what this guy does. It goes to any striated muscle in your body, which could include your heart or your central nervous system. Okay. So this guy is not going to live in your intestinal tract. When it does get to your intestinal tract, right, the very first part, once you eat it, you may get some diarrhea or some abdominal pain, some vomiting. But after that, it's going to go to that migration phase, and it's going to go find a place, and it's going to go there, and that's where it's going to insist. Yeah, that's where it's going to ball up, crawl into your muscle, and that's just where it's going to live. Okay. And here's a whole bunch of things that it causes: periorbital facial edema. I would say to highlight that because that's a very specific sign and symptom. Notice. And then conjunctivitis, macular rash. I have this splinter hemorrhage. Okay. Okay, so some of those splinter hemorrhages and petechial rashes are due from the inflammatory process and the vascular damage that this is causing as it's migrating to wherever it's going to go. And in some cases, it may cause some microthrombemia, which would cause some of the splintering in the smaller vessels, which is, you'll see those at usually the distal fingertips, most commonly. Now, if you look at the bottom there, it says life-threatening manifestations. If it does make it to your heart or your central nervous system, and it does cause you encephalitis and meningitis, if you don't address those immediately, that can lead to a high mortality rate. Okay, if you haven't seen splinter hemorrhaging, this is what splinter hemorrhaging looks like. You'll find them at the tips of the fingers. And the other one is periorbital edema and conjunctivitis. Okay. Diagnosis, often made clinically. Okay. When it's migrating is the only time you'll see eosinophilia. When it's just hanging out in your gut before it starts penetrating, you're not going to have any. Okay, so you got to catch it at the right time. Once it does make it to where it's supposed to go, then no more eosinophilia, but you can possibly start getting EIA or ELISA, where you can start getting your IgG and your IgM. These guys do like striated muscle, so we may be able to do muscle biopsies if you do see them. You can do a CT or MRI. All it's going to tell you is do 8 millimeter nodule lesions. The problem with that is that it doesn't identify and tell you what this thing is. Okay? It doesn't tell you what it is. So you're going to probably end up having to go in there and do a biopsy. Steroids, try to knock down some of the inflammatory process with this one. Okay? Albendazole and benazole are the big ones for treatment. Anybody have any questions? Cortisol infections. Candidiasis, giardia, leishmaniasis, crypto, adenosa, malaria, it'll be its own. It's not going to be within this. It'll be its own little talk that we'll have next. In toxoplasmosis. You guys remember toxoplasmosis from HIV? Okay, same toxin. This one's going to be geared more towards, because of cats, towards pregnant people. Okay. Most of these protozoa are usually transmitted via fecal oral route. Okay. Or there's some other ones that can be transmitted via arthropod infection. Tell you what they are: unicellular eukaryotes. These guys do play an important role in the environment. They maintain microbial balance out in the environment. They break down a lot of the decaying organic matter and releasing those nutrients back into the environment. So they do some good things for the environment. Other good things that they do, some of them are bacteria predators, which means they'll go after bacteria and they'll kill it, and they'll eat it. Right? So that's another helpful thing for us. Now, some of them can live outside, some of them need to live inside of us. So we're going to talk about the ones that are going to affect us. Any biases. Okay. This is amoeba histolytica, which usually hangs out in the large intestines. For this one specific, we're going to hone in a little bit more on the amoebic liver abscess. So once this thing goes down into your intestinal tract, usually the large intestine, the colon area. Okay. So now this one, more so for the colon specific, okay. It's going to do several different things. It'll have 3 different variations of forms that it'll be in. Here it affects about 10% of the world's population, as high as 50% in Central and South America, Africa, and Asia. Those are the large endemic areas. Okay. This thing usually lives in 2 different forms. When it's outside of the body, it's in a cyst form, right? And that way it protects itself from the environment, it allows itself to survive. And then once it gets inside of our body, it becomes a trophocyte. And that's when it becomes invasive and starts causing this disease. If the trophocyte is outside the body, it dies. It has to be in a cyst form in order for it to live. When I said amoebiasis interlytica, is amoeba histolytica. Okay. Here it's just telling me that lytic is basically self-destruction, or destruction or breakdown, or destroying cells, which is what it's going to start doing. That trophocyte colonizes the colon, where it hangs out for a bit. It invades the intestinal mucosal barrier when we're talking about amoebic liver abscess. Once it invades the intestinal mucosal barrier, it gets into your portal system, makes its way up into your liver, and that's where it creates your liver abscess. Can it go anywhere? It can go anywhere it wants, but in this case, most common, we're going to talk about it invading the liver. So amoebic colitis. So we know that this thing hangs out in the colon, right? Because we know it hangs out in the colon, it can do a couple of things. It can just hang out in the intestinal tract, 1. It can hang out into the mucosal and submucosal area, 2. Or it can penetrate through your intestinal wall and go and invade any other organ in your body. Most commonly, your liver, right? In this case, when we talk about amoebic colitis, the second one, the one that starts infecting your mucosa and your submucosa, is going to cause hyperinflation, hyperreaction of your body, which may inflame your colon. If you get an inflamed colon, depending upon how bad it is, it may become fulminant or necrotic. So if you look at the bottom here, you have fulminant or necrotizing colitis. So if it gets too swollen, too irritated, it may block off some of the blood that's going to that site. Okay? The more common folks to get that are poor nutrition folks, which are the ones that are in the endemic areas, right? Corticosteroid users, because that causes your immune system to drop in a very young age, because they've got smaller areas to work with. But if you do end up getting that, that is a medical and or surgical emergency. They need to be hospitalized, they need to get meds, and or they need to get linked up with a surgeon to figure out whether or not you're gonna have to do surgery. Now, as that thing is invading your mucosa and submucosa, it's gonna cause you abdominal pain, it'll cause you diarrhea, and it'll cause you blood stools. And in this one, you can highlight rectovaginal fistula as well, because if there is a channel that'll lead you from your rectum to your vaginal area, the amoebiasis can go into your vaginal area and start causing problems as well. All right, this one's specific. Once it becomes extra-intestinal, right, outside the intestine, over to the liver area, you may have some fever, you may have right upper quadrant pain, because that's where your liver is at. Usually, it is one cyst, usually. Usually, it's in the right lobe of the liver. And it will continue to grow. A lot of times, it's a subacute presentation. And if you guys remember what subacute means, it just means that it's developing really, really slow. And when things develop really, really slow within the body may not react to fight against it. Right? So that means that that little abscess is going to continue to grow unchecked. Now, some of the things that this little abscess does is it continues to grow. It may break through the liver, and it may start affecting its adjacent organs. Okay? The liver abuts the diaphragm. The diaphragm abuts your lungs. So this thing may continue to grow, break through the liver, and continue to affect your diaphragm. It may affect your pleural area in your lungs. It may break into your lungs if it is not taken care of. So we got to make sure that if we do find these, that we address these pretty quickly. Now, here it says that we have prominent weight loss. Now, remember, this thing is causing a systemic inflammatory response, setting off a bunch of cytokines. Okay, those cytokines would be tumor necrosis alpha, interleukin 1. Interleukin 6, which is trying to help you, right? It's trying to fight this thing. But that over-inflammation and that over-inflammatory part isn't necessarily helping. Those things are also causing catabolysis, right? It's causing the breakdown of muscle fat in your body because of the hyperinflammation that's going on in your body due to those interleukins. It's going to reduce your appetite. Okay? It's going to signal your central nervous system to, hey, I got some stuff going on, man. You need to tell the body. So it'll spur off a fever. Okay? And then the fever is going to increase your caloric expenditure. Right? So these are all reasons why you end up with prominent weight loss with this. So it's a cascading effect. So here are the more common findings with amoebic colitis. That's just your colon swelling up versus your amoebic liver abscess, which would be extraintestinal because it's broken out and gone someplace else. Right? There's a whole bunch of more common symptoms. With that one, we have right upper quadrant tenderness and fever for amoebic liver colitis. And here, look, it says heme positive stools. So somebody needs to make sure that you ask that patient whether you want to do a DRE or not. In this case, you need to, because you need to know. It may not be as evident to them in your stool. Right, so lab for imaging. I need you to remember enteric parasitic panel, EPP. Okay? That's generally what we do over here at Banksy. If we're looking for three different things, if we're looking for enterolytic, amoebic histolytica, which will be amoebiasis, if we're looking for Giardia, and or if we're looking for cryptosporidium. Okay? So if you remember those three diseases, Giardia, cryptosporidium, and amoebiasis, EPP will find them for you. Okay? EPP will find either of those three for you. Okay? So you don't have to worry about other stuff. In which case, you can still do a stool antigen or EIA for blood, or EIA or ELISA for blood serum. Your IgG will kick in for extra-intestinal stuff. If it is intestinal only, your EIA and your ELISA probably won't be up at all because it's not systemic. And if it's outside your system, for example, in the liver, you can also do that ultrasound or the CT scan. Just remember that you may find something, but you're not going to know what that something is that you found. Right? And then if they are just hanging out in the stool, in the intestine, then you may see the eggs in the stool overpaid. Now, I need you to understand this slide for treatment. Okay? I need you to understand this slide for treatment. Okay. If it is extra-intestinal, I need you to treat with either metrodiazonal or tindazonol and hydroquinol or paromycin. Okay? It'll be 2 meds for extra-intestinal. The ones that say luminal agent will be treatment for asymptomatic people. Okay, if you are asymptomatic, you only need a luminal agent. If it is more, and you've got a bunch of symptoms, and it's extra-intestinal, you will treat with metrodiazonol or tindazonol, pick one, and hydroquinol and paromycin. Okay? It'll be 2 meds, or if you're symptomatic, or if it's extra-intestinal, 2 meds. If you're asymptomatic, then you just need to treat with one of the luminal agents. Everybody understand that? Yes? Okay. So the metrodiazonol generally is going to kill the amoeba, but the luminal agent is going to kill any remaining amoeba in the intestinal tract, which is why for symptoms and anything extra-intestinal, you're going to do 2 meds. And for anything that's just in the intestine, you're going to just do 1 med. Right? That's the main reason. The most common one that we use would be metrodiazonol and hydroquinol. But you can pair them any way you want. All right? And then if you do end up with fulminant colitis, okay, get with a surgeon because they may have to be surgeon. That thing perforates, that's emergency. Here's a bunch of differentials so that you can stay smart. People ask you, hey, what else could this be? There you go. All right. Let's go ahead and take a break. Water, food, and by fecal oral route. A lot of times, the folks that end up getting this are usually campers or hikers. Usually when we're out there, we have some hand hygiene problems. So it is a way to spread it. Okay, uridiasis, lamblia, is your parasite. You can identify them in the stool because they do hang out in your intestinal tract. Here you're going to see that you have asymptomatic carriage, 3 to 7%. So 3 to 7% of people that actually have it don't have any symptoms, but they can spread it. Okay, but they can spread it. And there it says it persists for months. So you're spreading this stuff for months, unknowingly. Okay. And look at the folks that have high incidences: campers, backpackers in the western states, southern states, children in daycare. Big deal with the children in daycare would be hand hygiene, right? They don't wash their hands, or they start touching other stuff, you can spread it that way. Incubation period is usually about 1 to 14 days, but Giardia itself may last 1 to 3 weeks. It's a little different for everybody. Fecal oral transmission with contaminated water ingestion is one of the common ways that the campers and packers usually get it. This causes malabsorption. There are some mechanisms not fully understood, but not necessarily. Right? What happens is, once you ingest it, right, it goes into your intestinal system. It attaches to the epithelial cells. They don't invade your intestinal lining. They just hang out on the lining, on the villi, on all the things that your intestine uses to absorb stuff. So it just covers them up. Okay? It just covers them up. And it covers large areas of them. Okay? So when it covers large areas of your intestinal tract, it interferes with the absorption of your nutrition and your nutrients when you're eating, right? So that's usually what happens with these guys. Now, when it covers a lot of the area, it inhibits the absorption of fats, one, right, causing steatorrhea. If you remember what steatorrhea is, it's that greasy, foul-smelling stool. So that's what you're going to get when you have Giardia, because it's blocking it up and it's not allowing that fat stuff to absorb. So that fat is also fermenting in your intestinal system as it's going out. So it's also causing gas and increasing the smell, because it smells things. It also blocks your carbohydrates from absorbing. And when it does that, that causes bloating and gas in your intestinal system. The other thing it's inhibiting is protein and vitamin absorption, because now you're going to get that anxiety and that irritability, and sometimes if we're talking about B12, we're talking about anesthesia type stuff. So it's doing a lot of things in there because it's blocking the absorption of all your nutrients that you're eating. Okay? And here's all the places around the country that have it. The ones with N's means that they do not report Giardia. Okay, so we don't know in the ones with the N's, we don't know if they've had Giardia in those states. So here's the signs and symptoms: diarrhea, malaise, abdominal distension, flatulence, abdominal cramps, nausea. Okay, you can highlight the malodorous, frothy, greasy stool that may float. Right, we just talked about some of that stuff. Your body's not absorbing that fat, so it's all getting pushed through. Anorexia, weight loss, vomiting, various neurologic symptoms. As this thing blocks your absorption of nutrients and vitamins, you're going to end up with some of those symptoms as well. All right? Okay, physical exams, usually no specific findings. You will or may have some abdominal tenderness. If it has gone on a little bit longer, you may have some distension in the gut from the bloating. Okay, just like all the other ones, EPP, most of the others, just like antibiotics. Okay, EPP. Remember, EPP does Giardia, antibiotics, and cryptosporidine. Now here you can also do your enteral test, that little string test, put down your gut if you want. It's another possibility there. You can do some abdominal x-rays. You can try to do variant as well. But maybe non-diagnostic. It'll tell you something maybe there, but not necessarily what's going on. Right? So this is what that looks like. And if you're unaware, we're looking at the small and large intestine here. Right? This whole area here should look like this, or like this. Okay, this is where your small intestine is. Okay, and you can't see anything. Alright? That means that that area's got no erosion at all. Okay, so what do you use to treat? Tindazole or metronidazole. This stuff usually can resolve on its own within 1 to 3 weeks. If it does get bad, you just go ahead and treat it. Folks do have comorbidities, go ahead and treat it. Here's a differential diagnosis if you guys want to be smart. You might say, hey, what else is it? So leishmaniasis. Okay, this is transmitted by sandflies. Sandflies don't fly. Sandflies jump. So they jump about knee high. Okay? Sandflies don't fly. They jump about knee high. Okay? Remember, other cultures overseas sleep on the ground. As they sleep on the ground, this can get on your face as well. When you're sleeping. Just keep that in mind. There's 3 forms that we generally talk about. Could be the cutaneous, mucocutaneous, and visceral form. Found in 88 countries, tropical, subtropical, rainforests, Central and South America, West Asia. Okay. So 90% visceral leishmaniasis is found in India, Bangladesh, Nepal, Sudan, and Brazil. Okay. Visceral leishmaniasis is the bad. The cutaneous isn't extremely bad. The mucous cutaneous one can be very deforming, but the visceral one can kill you. And the visceral one can end up coming back as well. Right? So remember, this thing is spread by sandflies. The sandfly is not initially infected. The sandfly has to bite somebody or something infected, and then it comes and bites you and passes on that infection. Okay? It's generally the way it works with all these mosquito-borne diseases. It has to bite someone that's infected before it passes it on. So here we've got cutaneous, mucocutaneous, visceral, and viscerotropic. Visceral and viscerotropic we lump together. Viscerotropic is visceral's little brother. It is similar, but it is self-limiting, and it is a lot milder than visceral. Okay. So for cutaneous, you have localized diffuse leishmaniasis recividans. Okay, it is spelled correctly. Okay. Usually is recurrence of a lesion at a site that has already been healed. Right? A lot of times when you have cutaneous leishmaniasis, it may end up going away on its own, right? Even if you don't do anything. But because of recividans, years later, it may end up coming back in the same exact spot. That's what that means. And the next one, the post-Kala-Azar dermal leishmaniasis, we have under cutaneous because it's a cutaneous form, but it is a status post-treatment of visceral leishmaniasis that will lead to post-Kala-Azar dermal leishmaniasis. And that post-Kala-Azar dermal leishmaniasis can be very deforming in some cases. And what happens is you treat visceral leash, it's cured, it goes away. Years later, it may end up coming back and start causing you cutaneous forms in different parts of your body. That's what that is. Those things could be hypopigmentation, nodules, patches, anywhere on the body. So that one's really bad. Okay, so vector-borne, right? You said it was a sandfly. There's 30 species, 21 affect men. They're morphologically indistinguishable. So the sandfly bites you. Right? It releases promiscuous your macrophages go and try to kill those things, but they don't. Those promistogotes transform into amistogotes, okay? And then they multiply by subdivision inside your phagocytic cells. That's really what happens. And it just continues to replicate inside your phagocytic cells. Yeah, here's your little sandfly. Yeah, this one is not going to be on the test. This is just a stat slide. Right. As you can see, Iraq, Kuwait, Afghanistan had some cases. I had a couple of cases in Afghanistan. Okay, so two main forms. We break it down: cutaneous leishmaniasis and visceral leishmaniasis. Now, cutaneous is usually painless. Okay? Cutaneous is usually painless unless you get a secondary infection, then it becomes painful. Okay? It starts off as a papule and then becomes a large ulceration. Okay? And that can persist for months to years, but it generally heals itself. It may end up being self-limiting, but we can always try to help it. We can always try to help. The visceral leishmaniasis, on the other hand, there it says Kala Azar. So Kala Azar means black fever in Hindi or Urdu, right? And what happens is you end up getting irregular fever, sometimes pneumonia, pancytopenia once you get the visceral leishmaniasis. But the Kala Azar aspect of leishmaniasis, and they're not quite sure. They think it increases your melanocyte activity, and because your immune system is hyperactivated, it's also affecting your adrenal stress. So you end up getting more coloration in your body, causing you to become darker, which is why they call it black fever, or they used to call it Kala-Azar overseas. And that usually becomes later in the visceral stages of infection. And there's a whole bunch of different things that determine which one you get, right? Because the question would be, all right, which one am I going to get? Am I going to get the cutaneous one, or am I going to get the visceral? I don't know. We don't know. Okay? There's a bunch of possibilities. It really depends on the species that bites you, right? It depends on the geographic locations. You saw we had, 8 different places where visceral leishmaniasis is more common, right? And then your immune response, your health, right, is going to determine which one you're going to end up getting as well. And so there's a lot of determinations as to which one you end up getting. We're just not quite sure. But here for the cutaneous one, it usually occurs at the site where you get bit. Okay? So the site where you get bit is where you start getting the little capule and you become, the ulcer starts breaking out. Now remember, the sandfly does not fly. So what it does do is it hops around. So there it says one or more sores, which means it may bite you in one spot, you move, and it just jumps to another spot. And it continues to bite you. And if you continue to move, it may just jump. So you may have a little line of these little sores. Okay? They change in size appearance over time. It usually gets bigger, right? Has raised edges with a central crater. A lot of times I liken it to a little pizza. That's kind of sort of what it looks like. It may be wet or it may be dry. Okay, you can have possible crust in your scab, and here it's telling you it's painless or painful if you have a secondary infection. Okay, and remember you have exposed under skin there, so the likelihood of you being infected becomes a little bit higher depending upon where it is. Now, the other thing about this one is depending upon where it is where you'll have regional lymphadenopathy, right? So if it's on your hand or arm, the closest lymph nodes that you'll have will be under your axilla. So the regional lymphadenopathy is going to pop up because your body is actually capturing some of this stuff and trying to make it go away. Okay. That's what cutaneous. This is kind of what it looks like. Here's your raised borders. Okay, very telling. Raised borders. The middle area kind of looks like a little pizza, right? So key aspect to leishmaniasis if you are going to do a biopsy. Okay? You're going to do a biopsy. Your biopsy needs to be done out here. Okay? Most of the time, biopsies are usually done in the middle. Right? Not the case for leishmaniasis. For leishmaniasis, you need to be out here. Okay? This is where all the little bugs are. That's where all the parasites live, right out here. Okay? So you need to take your biopsy out here and you're doing a skin biopsy for leash. The edges. See? Look at that little pizza, right? So they can be wet or they can be dry. Here's another one. This young lady had it on her face. Okay, this is diffuse cutaneous leishmaniasis. Deforming, right? Here's another one on the back of the hand. Okay. So this is what we tell you when they don't fly, they jump. So if they get disturbed a little bit, they'll start here, and then they jump here, or they may jump here, or they may jump here. So you may have a little line of them. Okay. So for the visceral Salazar or black fever, which is AKA, this is the most severe form of leash. Right? This is the worst ones that you can have. It is systemic. It can affect the liver, the spleen, bone marrow. You can have recurrent high fevers, weight loss, splenomegaly, hepatomegaly. The hallmark for this one would be the darkening of the skin. Okay? And generally, later on in the disease process. And it can be anywhere on your body, your face, your hands, your arms, your feet. This post-Salazar dermal leishmaniasis is what we talked about a little earlier. So when you cure or take care of or eradicate visceral leishmaniasis, it goes away. Part of the problem with that is that years later, you may end up getting something called post-Salazar dermal leishmaniasis. And that looks very similar to that gentleman that we saw with the nodules all over his face. Okay? They'll get subcutaneous nodules, but it'll all be derm related. And that's the thing with this one, it's all derm related. But that'll happen years later, after you've already cured your visceral leishmaniasis. And then here it's telling you that this can be an opportunistic infection and it can coexist with HIV. Not necessarily here in the States as much, but more so overseas in endemic countries. So physical for cutaneous, systemic signs are usually absent, right? It's just diagnosis by looking at it. And if you want to do a skin biopsy, you can. There are initial red papules, ulcerates, raised edges, crusted scabs, maybe exposed areas of the skin. It could be on the extremities, it could be on the face, it could be anywhere. Right? You may have some regional adenopathy. You can have some satellite lesions. What that means is you may be following some of your lymph nodes, so it may be spreading just around the main ulceration. And then you can have some cutaneous nodules, which is basically the same thing. The infection can be spreading to different parts, but pretty close to the initial infection. And that's just an inflammatory process for the skin. And for visceral, you'll have bouts of fever, hepatosplenomegaly, wasting, weakness, darkening of the skin, which is a hallmark characteristic of this one. Diarrhea may occur, and cytopenia is common because your whole body's trying to fight it completely. So your whole body's this little kid with some kind of hepatosplenomegaly and some darkening of the skin already. If you look at his arms over here and here, you can see the outer portions of his chest are already starting to darken up. There's probably hepatosplenomegaly, probably some wasting if you look at his arms. Same thing with this one. You can see the outlines that these guys have drawn, colon. It looks like some wasting going on there. This one is more so an isolation of the organism. And you can take it, you can gram stain it, and you can look at it under the microscope, and you're looking for the amistogotes that form inside the body. That's really what you're looking for under the microscope. So if you don't know what you're looking for, you may not see it once you stain it with the gram stain. Okay. For cutaneous stuff, serology doesn't generally work too well. We can do ELISA. ELISA usually works a little bit better if we're talking visceral versus cutaneous. Cutaneous is just a visual clinical diagnosis. Okay. Cultures don't do too well with leishmaniasis, but we can do PCR if you have. Generally, where this stuff occurs, PCR is not available. Okay. So that's generally one of the reasons why we don't have PCR on all these things. But definitely serology for visceral. Well, this is kind of where it gets a little bit hazy. Okay, so I need you to pay attention to this part. If you have less than 4 lesions, and they are less than 5 centimeters in size, then you can treat them as an outpatient. If they are not on cosmetically visual areas, i.e. your face, hands, your feet, right? You can go ahead and treat outpatient. Here it says pearlmycin, you know what means? That is ointment, right? That is ointment. So you give them some ointment. LN2 means liquid nitrogen. Okay. I would be careful using liquid nitrogen. I would talk to an IV guy. Big reason why I'd be very careful is because you have exposed skin, like the top layer of skin is almost completely gone. So you're really going to start shooting unexposed top layer of skin gone. So you're going to really be using liquid nitrogen, but you have to be very careful with that because it can really cause some serious ulceration. Not because of the disease process, but because you freeze the cells too much, too hard, and you'll cause more damage than you're actually generally helping. Okay, so be careful with the liquid nitrogen. I would talk to an IV doc before I use that with leishmaniasis. Here it tells you spontaneous resolution. I found here it says 6 months, anywhere between 6 months to a year for cutaneous, standard cutaneous ones. I've had a couple in Afghanistan where I've given them some cream, and then they're like, yeah, it got better, and went away. All right, great. You don't have to worry about it. But if you do, and it does continue to go on, you probably should send them off to a dermatologist or an IV guy if you think it's leishmaniasis. All right? But understand, less than 4 lesions, and they should be less than 5 centimeters, and not on cosmetically sensitive areas. And you could probably just treat outpatient. No issues, no problem. Right? Got that part? These are cosmetic areas or other issues where you should be aggressive with the therapy, right? If it's on the face or a cosmetic area, you should really be aggressive because you don't want any of that deformity to occur like that gentleman we saw. Right? So we need to be aggressive. If it's already been months and it has not healed or gotten better, then just go ahead and treat. If it involves joints, treat. Hands and feet, due to possibility of secondary infection, and I consider those cosmetic because people see those, right? Treat. Okay, there it says local dissemination. If you're already starting to get satellite, if you have regional lymphadenopathy, LN means lymphadenopathy, okay, or sporotrichosis subacute, that just means that it's starting to follow and track your lymphatic system. So you're going to start getting little ulcerations going up your arm or away from that initial ulceration. Okay, go ahead and treat. That means it's starting to disseminate. So go ahead and treat. Definitely for the immunocompromised folks. Okay, and then right from the last slide to this one, anything greater than 5, right? Go ahead and treat. And obviously, if it's larger than 5 centimeters, go ahead and treat. How do you treat? The first two, hey, don't pick those on a test. Right? Don't pick those on a test. Look, hard to get, not FDA approved. Why do you pick that on a test? We put those on here because what we need you to understand is when you're overseas, you get exposure to other medications. When you don't have any, maybe your partner nation does. Right? I work with UK folks, and there in the UK they have Pentostan. That is a viable solution I can give somebody. It's not FDA approved, but guess what? That's the only thing I got. That's what I'm gonna give them because I know it works. Right? Been in places where we've been able to go to local pharmacies and pick up some stuff that we don't have. Right? When we talk about deployments. Right? So those two, right? Because I've also worked with folks from France, so they've got the two meds. Okay? We don't. Okay? But if you do need it, and you have a partner nation, hey man, you guys got anything for a leash? Right? You can borrow some other stuff, right? But if we're in the US, okay, liposomal amphotericin B, or Improvato, milfistone, or fluconazole. Fluconazole is in all, the only reason why I put that in there is because it's in all our MDS kits and outfits. So we have, okay, that'll be okay to initially treat cutaneous. But if we're gonna treat, let's go ahead and treat with what we got. So liposomal amphotericin B or milfistone, flocine would be the two that I would pick. For any of them. For any of them. Okay? If I didn't have anything, then I would pick for fluconazole. Okay. But the first two would be the two main ones that you should use to treat leishmaniasis. Okay. Any of the leishmaniasis, any of them. All right. And then that thermo-med radio frequency, that's basically in dermatology. We don't generally have that in standard general practice for family medicine. All that does is it transmits radio frequency at a certain level where it heats up the cells individually and maintains it at that specific temperature for X number of time. And there it tells you 3 treatments at healing rate of 73%. But again, that'd be you sending them off to derm, and derm may have that 20. Okay? We, in family medicine, do not, but it is another option. So the two medicines that you really need to use for this, if you do have it for any of them, will be liposomal amphotericin B and the milfistone. Those two aren't there, they could do constantly. But otherwise, those two are your main treatments. Okay. Questions for that? Okay, if you want to be smart, there's a couple extra differential diagnoses. Right? Cryptosporidiasis is infection with the protozoa Cryptosporidium. Okay. Now, healthy folks, not a big deal with this thing. Healthy folks, not a big deal. Right? Here it says high seroprevalence in the healthy folks because if we have gotten it, our IgG, IgM is already sitting there waiting to take care of it because we're healthy, no issues, no problems. Usually we end up being asymptomatic. Immunocompromised, on the other hand, children here, 1 to 5 years of age, men who have sex with men, are at a higher risk for this. Okay? So for us, we have a very low mortality rate, but it's up to 50% of people with AIDS. And this is considered an opportunistic infection. Here's all the places in the country that have it. As you can see, basically every state. Okay, Cryptosporidium, Parvum hominis. Okay. Contaminated water or recreational water, pools. Okay. This is a fecal oral thing as well. You just need 30 oocytes, just 30 of them, and you can actually infect you. Here it tells you, even if you're in recreational water, this thing is resistant to chlorine. So folks that are in pools may still be able to spread it if someone else jumps in the water with this. Even though it likes to live in the genome, but for us, it's self-limiting. Healthy folks, self-limiting, it's not a big deal. Here's the asymptomatic part of the report. Most of us, little kids will end up getting watery diarrhea, occasional pancreatic involvement, weight loss, abdominal pain, fever, nausea, vomiting. Okay. Usually this stuff doesn't last very long for us. If we do end up getting any symptoms, it usually goes away within a week or two. Okay. For the immunocompromised, especially less than 50 CD4 count, it's really bad for them. Okay. We have no treatments for them. Okay, we have no treatments. So what we do for those folks with CD4 count less than 200, in this case, we usually have folks with less than 50. The mainstay treatment for these guys is to get that number back up. So heart therapy is really what we do for these guys. For us, we can do some antiparasitics, but those antiparasitics are not helpful for folks that have AIDS or are immunocompromised. Okay. But here's some physical symptoms: abdominal tenderness, right upper quadrant, epigastric pain, hyperactive bowel sounds. Icterus and ascites are pretty rare. That usually doesn't happen unless we take a bad turn. And just like the other two that we talked about, epidiasis and giardia, EPP is what we'll use to find this in labs. If you really need to, you can do a gastrointestinal biopsy. That would not be you, that would be a doctor. Okay? If you really need to, you can try to use EIA or ELISA, looking for antibodies or antigens. Imaging doesn't help at all. Okay, here's your treatment for immunocompetent folks, for healthy folks. No therapy required. If you do need to or want to give something because you think these guys are taking a bad turn or the symptoms are really bad for them, you can give them nitazoxanide. Okay, that is an antiparasitic. So that'll go in and it'll kill a lot of the parasites, but your body has to come in and do the rest of the work. Okay? That is the main reason why we don't usually give that to immunocompromised folks, because their body's not going to come in and do any extra work because it can't. Right? So the main therapy and mainstay for immunocompromised folks is heart therapy, okay? Or ART therapy for them. You need to get those CD4 count numbers back up so that their body can start fighting against this stuff. If you want to get smart, here's some differential diagnoses. All right, babiosa. Okay. Anybody from New York? You guys remember Long Island? Okay. There's a place. I used to go to school in New York Tech. New York Tech is out in Central Islip. The train that I used to take went towards Babylon. So every time I hear babiosis, I think of Long Island. Okay? That's the way my brain works. All right? Where do I find this thing? I find this thing in Long Island. Right? So that's the main reason for that little story. So remember the endemic areas, right? Because when I put you in a scenario or a vignette, I am going to put you in an endemic area. The endemic area for this is northeast, northwest region of the U.S., i.e. Long Island, New York, Nantucket, or Martha's Vineyard, Massachusetts. Okay? So keep in mind your regions and your locations. Okay? Internationally, this thing does happen over in Europe. This is a tick-borne disease. Okay? This is a tick-borne disease. And it's a could bite you, and then you get it. Right? Real simple, real easy. Except for those areas up there have woods and they have big grassy fields where you can walk by and the ticks will get on you and bite you. Right? This stuff usually happens more so during the warmer months, because that's when those little ticks are out. Right? Okay, this is a zoonotic disease. It's a tick-borne. It says malaria-like, and when we say malaria-like, a lot of times we mean that it has up and down fevers, right? But this doesn't have up and down fevers. Okay, malaria-like because malaria infects red blood cells. Okay, when red blood cells break at every specific time frame, that is based on the malarial species. For babiosis, it infects the red blood cells as well, just like malaria does, but it doesn't have that same time. So some of them are at different time periods, but some of the symptoms are still the same. Right? You're still going to get a high fever, you're still going to get some hemolytic anemia, you may get some jaundice, and you may get some renal failure. Okay? Same stuff that you may get in malaria, which is why they call it a malaria-like disease. Okay? And there it tells you results from the capillary blockage may result from the fragments of the red blood cell breaking. Right? So when you get bit, these things go, float around, get into your red blood cells, continue to procreate. As soon as they grow big enough, they rupture that red blood cell and goes out and finds more red blood cells. Okay? So it can affect your spleen, central nervous system, kidney, liver, usually from the fragments. Okay? If you're asplenic, this is not a good disease to have, right? Because you're going to have so many fragments in your system that your body is going to find it very, very hard to clean up. Okay. All right, so symptoms, fatigue related to severity of hemolytic anemia. So depending upon how many red blood cells are ruptured, you may end up with fever, okay, fever, chills, diaphoresis, prostration. Okay. And that's based on the parasitemia of how many red blood cells are actually affected. You guys remember what prostration is? That just refers to a state of being extremely weak or exhausted. That's all that means. Okay. Okay. So here, history of splenectomy. Okay, it's poor prognosis. Right? All those red blood cells are being fragmented in someplace. Someplace in your body has to clean up the mess, and then usually it's a spleen. But if you don't have one, it becomes more difficult. So you may end up having overwhelming infection with the outcome. Okay? Older folks and immunocompromised folks have a worse outcome. And there it tells you maybe transmitted in utero or through blood transfusions. So maybe it will spread this to the baby. And there's two different kinds. You have the divergence, more severe than the necrotic. The divergence is usually found over in Europe, and the microtia is usually found more so in the U.S. Okay. Here's some physical signs and symptoms. Okay. You don't really have too much unless it gets really bad, or you end up with jaundice or splenomegaly. Okay. If you do a staining, GEMSA staining, you may end up getting what we call Maltese cross. We don't really see them here too well yet because they haven't wholeheartedly developed. I think we have some here. Yeah, I think after this slide we have it. So we'll do a Reiter GEMSA stain. You can do thin blood smears. We look for rings. Okay, so that's one of the things. So these are your rings. Right? Right in here you can see the rings. Okay. And then the other one will be the Maltese cross formation, and that's the pathognomonic one. And on the next slide we'll show you that. You can do serology titers for IgM and IgG. CBC, obviously, you'll see the anemia because of the loss of all the red blood cells. And at ESR, just it's an inflammatory process all over the body. And your teeth may be a little bit elevated. Okay, so here, these are your Maltese crosses right here, and these are the pathognomonic ones. So you'll have your ring initially, and then after that, it'll develop into this, and then it'll go usually to a cross. Okay, so how do you treat etablockbone and azithromycin or clindamycin and quinine? We just have to be very careful with quinine medications. Right? You don't give them to people with G6PD. Okay. If it is really bad, then we can do the second one, but generally go with the first one. You also need to give them support therapy. The severe ones, you need to make sure that they end up in the hospital because if they are severe and they have so many red blood cell fragments in their body and they have so much parasitemia. When you do transfusion, you're going to try to pull out as much of that stuff and put it back into the system clean, especially if you have no spleen to clean that stuff out. Okay? So extremely important to get into the hospital, more so for that transfusion if you need it. Okay? If you want to be smart, there's a couple of other differential diagnoses. Lives of malaria probably be the top two that I would pick for differential diagnoses because they look somewhat similar. Right? Lyme's disease is also spread by a tick, okay? But malaria has similar signs and symptoms of babiosis. All right? Anybody have any questions? I'll be up here for a bit if you guys have questions. And thank you.